In medicine, there's this standard algorithm for almost everything. You see a mass, you panic a little, but then you follow the steps. Inspect, palpate, and crucially biopsy.
Right.
You need that tissue sample to know what you're up against.
Tissue is the issue. I mean, that's the golden rule they drill into you. If you don't have the cells under a microscope, you're just guessing.
Exactly. But today, we're talking about a condition that completely flips that rule on its head. We're looking at a tumor where that standard procedure...
Sticking a needle in it.
Yeah, sticking a needle in it to see what it is can turn a routine consult into, well, a life-threatening catastrophe in seconds.
It's the ultimate bear trap for an unsuspecting ENT resident. It's a scenario where doing what you were trained to do for every other tumor is the absolute worst move.
So today, we're doing a deep dive into the juvenile angiofibroma, often just called JA or JNA. And I have to say, looking at these surgical guidelines and case reviews, this thing is a total paradox.
How so?
It's benign, yet it eats through the skull base. It's rare, yet missing it is. It's considered a career-defining error.
It's a masterclass in anatomy. I mean, if you don't respect the geography of the head and neck, this tumor will humble you, and it will do it very quickly. It forces you to understand embryology, radiology, and surgical restraint all at once.
Okay, so let's start with that red flag, the profile. Usually, when we talk about risk factors, it's vague stuff like diet or family history. But for JNA, the demographic is basically the diagnosis, isn't it?
It is remarkably specific. I mean, if you are reading a case file and it says adolescent male aged 14 to 25, and he's got a nosebleed, you have to think JNA. It is almost exclusive to that group.
Almost exclusive. That implies there are exceptions. Can a girl get this?
Practically speaking, no. There are a handful of case reports in the literature claiming to find them in females, but usually when those get re-examined with genetic testing,
They turn out to be something else.
they turn out to be misdiagnosed polyps or other masses. For the purpose of your board exams and, for clinical reality, this is a disease of adolescent males.
Which just begs the obvious question, why does it? Does the tumor feed on testosterone?
That is the leading theory. We know these tumors express androgen receptors. The idea is that this tissue, it just sits there dormant during childhood.
Lying in wait?
Exactly. And then puberty hits, testosterone floods the system, and it's like pouring fertilizer on it. The tumor wakes up and starts to expand.
So we have a teenage boy. He comes in probably complaining of stuffy nose. But the hallmark isn't just, I can't breathe, right? It's the bleeding.
Correct. And we need to be really clear about what kind of bleeding this is. This is not a spot of blood on the tissue kind of situation.
No.
This is recurrent profuse epistaxis. We're talking about nosebleeds that are hard to stop, often unilateral, so just one side, and significant enough to actually make them anemic.
And that gets to the biology of this thing. Why does it bleed like that? I mean, lots of tumors have blood vessels, cancers have blood vessels. Why is this one a fire hose?
It comes down to the histology, the microscopic structure. A normal blood vessel has a muscular layer, the tunica media. When you cut a normal vessel, that muscle reflexively contracts. It clamps the pipe shut.
Like a built-in safety valve.
It is, but JNA vessels,
They don't have that.
they lack that contractile muscle layer. They're just these fibrous, rigid pipes. So if you cut one or if you biopsy one, it cannot clamp down. It just stays wide open and pours.
Wow.
That's why we tend to think of it more as a vascular malformation than just a tumor. It's basically a high-pressure knot of defective plumbing.
Which explains the do not biopsy rule. You stick a forceps in there, you are opening a tap you cannot close.
Exactly. And that's why the diagnosis has to be made with your eyes and your scanner, not your scalpel. You have to recognize it on the imaging before you even think about touching the patient.
So let's talk about that imaging, because this tumor has a very specific address. It doesn't just pop up anywhere in the nose.
No, it has a very precise site of origin. It starts at the sphenopalatine foramen.
Okay, that is a bit of a mouthful. Break that down for us.
So think of the sphenopalatine foramen as a doorway. It sits deep in the back of your nasal cavity on the side wall, and it opens into this little hidden space behind your cheekbone.
The pterygopalatine fossa.
The PPF, yeah.
So it's tucked away in this little crevice behind the sinuses.
Right. And that small space, the PPF, that's the key. As the tumor grows inside that tight little box, it runs out of room. So it has to push against the structures around it.
And that leads to that classic exam sign I saw in the notes, the Holman-Miller sign.
Yes. This is arguably the most important radiological clue you can get, because the tumor is pushing from behind the maxillary sinus, it's the big sinus in your cheek. It physically bows the back wall of that sinus forward.
So on a CT scan, instead of seeing a straight wall at the back of the sinus, you see a curve.
Exactly. It looks like the wall is being shoved forward by an invisible hand. We call it anterior bowing of the posterior maxillary wall. If you see that in a teenage male with nosebleeds, you can put the biopsy needle away.
You have your diagnosis.
You have your diagnosis.
Okay, so we've identified it. It's this vascular knot. It's hiding behind the nose, fueled by testosterone. But you said earlier that it destroys the skull base. If it's benign, so it doesn't metastasize to the lungs or whatever, how does it do that much damage?
Benign in the head and neck just means it doesn't spread through the blood to distant organs. But locally, it's aggressive. It follows the path of least resistance. It grows through fissures, foramina, these natural tunnels in the skull.
It was an explorer.
A destructive explorer, yeah. We categorize the spread to predict the symptoms. First, it pushes medial into the nose. That's your blockage and bleeding. That's usually what brings them to the doctor.
That's the visible part of the iceberg.
Yep. Then it goes lateral through the PPF into the infratemporal fossa. That's the space behind your cheekbone. In, really neglected or aggressive cases, you'll actually see the kid's face start to swell on that side.
Like a chipmunk cheek.
Exactly, facial deformity. But the really dangerous routes are superior and posterior.
Going up towards the eyes and the brain.
Exactly. It can travel through a space called the inferior orbital fissure and start pushing on the eye.
And what does that look like?
You get proptosis. The eye is literally bulging out or double vision because the muscles can't move the eye properly anymore.
And if it keeps pushing?
It can compress the optic nerve, and that means blindness. And finally, if it goes even higher or further back, it hits the skull base and the dura, which is the covering of the brain.
Wow. And I assume, given its vascular nature, it's tapping into the local blood supply to fuel all this expansion.
It's worse than just tapping in. It recruits. Initially, its main feeder is the sphenopalatine artery, which is part of the external carotid system. That's manageable. But as it gets bigger, it acts like a parasite. It reaches out and can steal blood supply from the internal carotid artery.
The internal carotid, that is the main fuel line to the brain.
Yes. And this is where the embryology gets really, really fascinating. The prevailing theory is that JNA is actually a remnant of the first branchial arch artery.
So we're going all the way back to when the patient was an embryo.
Right. In the embryo, that arch connects to the internal carotid. It's supposed to just disappear. But in these kids, a little piece of it that remains.
So when the tumor grows,
It's essentially reestablishing an ancient embryonic connection directly to the brain's blood supply.
that's incredible. It's like a sleeper agent that wakes up and reconnects the hard line.
It is,
Yeah.
and it makes surgery infinitely more complex because you can't just clamp the internal carotid without risking a massive stroke. It changes the entire game plan.
So let's get into that solution. You've got this vascular bomb sitting on the skull base, maybe drinking from the brain's own blood supply. How on earth do you get it out?
Well, it used to be a bloodbath.
Yeah.
Truly. Open surgery, cutting through the face, swinging the maxilla bone out of the way, just morbid stuff.
But not anymore.
Not anymore. Today, it's more like a heist. It is all about the prep work.
Preparation, meaning you don't just go in cold.
Never. About 24 to 72 hours before surgery, the patient goes to interventional radiology. They'll run a tiny catheter up from the leg into the neck, identify those feeding vessels,
And then what?
and then they inject tiny particles to clog them up. It's called embolization.
So you're shutting off the water before you fix the pipe.
Precisely. You want to turn a high-flow, bloody vascular mass into a relatively dry, fibrous tumor. It makes the surgery safer, it improves visibility. It's a game changer.
As it always done.
It's generally standard practice. There's some debate. Some surgeons might skip it to use the bleeding as a map or because of the tiny risk of stroke. But for most big tumors, yes.
And once it's embolized, you go in.
Usually endoscopically.
Yeah.
Through the nose, no cuts on the face. We use these high-def cameras and long instruments to just peel the tumor away. It's the gold standard now.
Peel. Sounds very delicate.
It has to be. The tumor has what we call a pseudocapsule. It's not a true shell, but it's a condensed layer of tissue on its surface. You have to stay strictly on that plane.
And if you don't?
If you dissect into the tumor, it bleeds. If you dissect too far out, you damage normal nerves and muscle. You have to ride that edge perfectly.
Now, there was one specific surgical step in the sources that seemed to be bolded, underlined, highlighted. Something about drilling bone.
Yes. This is the secret sauce for preventing it from coming back. Remember we said it starts at the sphenopalatine foramen?
The doorway.
Well, the tumor roots itself into the bone of the pterygoid base and the clivus. If you just pull the soft tissue tumor out, you're leaving microscopic cells behind in the bone marrow, and it will grow back.
So you have to actually drill the bone away.
You have to drill down the pterygoid base until you see healthy bleeding bone. You're essentially removing the soil so the weed can't regrow. Since surgeons started doing this aggressively, recurrence rates have just plummeted.
That is a key takeaway. The surgery isn't just removal, it's resurfacing.
Exactly. But
Yeah.
I have to play devil's advocate for a second. We talked about getting it all out. There are cases, very advanced cases, where you intentionally don't get it all.
You leave tumor behind on purpose.
If the tumor has wrapped itself around the internal carotid artery or the optic nerve, sometimes valor is the better part of discretion.
Meaning,
The risk of blinding the patient or causing a stroke is higher than the risk of a small residual piece of tumor.
because it's benign. It won't kill them tomorrow if a tiny piece is left.
Right, you can leave a small nub, you watch it with an MRI, and often it just stays dormant or grows incredibly slowly. We call it subtotal resection. It's a judgment call that separates the master surgeons from the cowboys.
That seems to be the theme of this whole condition, really. Restraint. Restraint in diagnosis, don't biopsy. Restraint in surgery, don't chase the tumor into the carotid if you don't have to.
It really is. Juvenile angiofibroma is, maybe 0.05% of all head and neck tumors. It's tiny. But it teaches you everything you need to know about surgical decision making.
So if we zoom out, what's the big lesson here? Aside from, don't stick needles in teenage noses.
I think the lesson is that benign does not mean safe. We are conditioned to think cancer is the only real enemy, but here you have a benign pathology that requires some of the most sophisticated, high-stakes management in the entire field.
Right.
It teaches us that anatomy is destiny. Where the tumor sits matters just as much as what the tumor is.
It's also just a reminder that our bodies are these historical maps. I still can't get past that embryology bit.
The first branchial arch.
Yeah, the idea that a 16-year-old boy is dealing with a life-altering surgery because a microscopic artery didn't fade away when he was 6 weeks post-conception.
Yeah.
It's just wild.
It's an embryological ghost. It waits 15 years for the testosterone signal, and then it tries to reclaim its old territory.
Well, for any listeners out there, if you see a teenage male with a black nose and scary nosebleeds, check the scan. Look for that bowed wall. And for the love of everything holy, keep the needle away from it.
Couldn't have said it better myself. Respect the anatomy.
That's it for this deep dive into the JNA. Thanks for exploring the skull base with us.
Until next time.